This video will cover Chapter 25, the peripheral nervous system. So the objectives, we're going to go through different lower motor neuron lesions and different conditions listed here. So the peripheral nervous system. So this includes sensory and motor components of the cranial nerves and spinal nerves that arise from cell bodies located in the brainstem and the spinal cord or the dorsal root ganglion. Signs and symptoms of peripheral nervous system include motor, sensory, and the autonomic nervous system. Disorders of the peripheral nervous system can very broadly be classified as neuropathies, meaning involving a nerve, and myopathies involving a muscle. So this should look familiar. We went through dermatomes in Kurt's class in A&P. So what we have here on the left side of the image here on the person, these are the dermatomes, so the different segments of innervation based on the spinal levels. On the other side of the person is going to be the actual cutaneous nerves that provide innervation to that component of the skin. I wouldn't worry about these as much as I would the dermatomes. So we've been talking a lot about upper motor neuron dysfunction and disorders. We're going to move to the lower motor neuron symptoms because we're talking about the peripheral nervous system. So commonly what we're going to see with lower motor neuron dysfunction is weakness. We're going to see hypotonicity, so low tone or flaccidity. We're going to see diminished or absent deep tendon reflexes. With a myopathy, we're going to see muscle weakness, and this is typically seen proximally. With a neuropathy, we're going to see nerve symptoms or sensory impairments. There's often a motor symptom that is associated with a neuropathy, and when we see motor symptoms associated with a neuropathy, those motor symptoms are going to be distal, which is the opposite of a myopathy. But just remember that a myopathy involves muscle, and a neuropathy involves nerve or sensory. We're going to talk about Charcot-Marie tooth disease, or CMT. It is a hereditary disorder. It results in motor and sensory neuropathy and muscle atrophy. It is also a progressive disorder. Typically, the muscles affected are the peroneals, and this can progressively affect the forearm and the hands as well, but if it affects our peroneals, we're going to see foot impairments primarily. We are going to see deformities, we're going to see weakness, we're going to see sensory loss, and abnormal deep tendon reflexes. So the image here is something called a pes cavus foot deformity, which is a high arch foot. So you can see here and the high arch here in these images. There's often going to be weakness of the ankle with our dorsiflexors and our everters, so those peroneals. And in order to compensate for this instability, we're going to have overactivity of our ankle inverters, which is going to result in that high arch foot posturing. Moving on to carpal tunnel syndrome. So this is the most common nerve entrapment neuropathy that you're going to see. It's going to be an entrapment of the median nerve in the carpal tunnel at the wrist. Signs and symptoms are going to include tingling and pain. This can progress to numbness and ultimately weakness, and we may see atrophy with a chronic carpal tunnel syndrome. This figure is from your book on page 746. Figure A here is showing the path of the median nerve and its motor innervation. Figure B is showing the point of compression at the carpal tunnel as that median nerve passes through the carpal tunnel itself. You can see that there's some different colors and shading on the fingers and the hand here. So the lightly striped area along the palm here. So what we often will see is there's actually a sensory branch of the median nerve called the palmar cutaneous branch, and that branch arises proximal to the carpal tunnel, and it doesn't run through the carpal tunnel, it runs over the top of it. So oftentimes someone with carpal tunnel syndrome will have spared any loss of sensation in this area here of the hand because of that palmar cutaneous branch. These darker, more densely striped areas, this is going to be the area of sensory loss from that median nerve entrapment that occurs. So typically, if I suspect compression of the median nerve, we're going to see numbness, tingling, and pain in the first 3 fingers, sometimes half of the 4th finger as well. Causes of carpal tunnel syndrome. You can see there are a lot. So typically, it's going to be from an occupational hazard, such as increased gripping, tasks that require a lot of repetitive motion with a lot of force. However, there are other more systemic conditions that increase the risk for developing carpal tunnel. And I broke them up by the different parts of the body. So within our neuromusculoskeletal system, okay, so someone with cervical issues can develop carpal tunnel syndrome, repetitive strain injuries, poor posture associated with thoracic outlet syndrome can be associated with carpal tunnel. Oftentimes, thoracic outlet syndrome is on here twice because oftentimes the median nerve is compressed within the thoracic outlet, which then leads to problems distally in the hand. Okay, so poor posture and thoracic outlet syndrome are probably common ones, contributing factors you're going to see. Systemically, there are again a lot of other contributors to the development of carpal tunnel syndrome. In the endocrine system, again, other contributing factors. My favorite, diabetes, is on here. Okay, gout, we will talk about that in the endocrine chapter. The other thing that is not on here that I mentioned in the last slide is repetitive stress at the wrist. All of those are major contributing factors to the development of carpal tunnel syndrome. So we're going to move on to idiopathic facial paralysis. This is often referred to as Bell's palsy. You may have heard of this before. This is a condition in which the facial nerve is affected unilaterally. So again, this is the facial nerve, and it is affected unilaterally. The cause of this is often unknown. However, they do suspect that it is a potential flare-up of a herpes simplex type 1 virus that becomes active. Risk factors for developing Bell's palsy are pregnancy and diabetes. Our clinical manifestations include paralysis of muscles of facial expression on one side. So you may see drooping in the corner of the mouth. We may see failure of the eyelid to close and flattening of the upper lip area. So this image here. So in this image here, we see this woman has right-sided facial paralysis. Something I want to add is how to differentiate between our upper and lower motor neuron involvement. So with involvement of the upper motor neuron, I have an image up here showing the pathways of our facial nerve. So if we have a lesion on the left side of the brain, we will see right-sided symptoms, okay, because it's going to cross over. So these patients will be able to close their eye and wrinkle their forehead, but they won't be able to smile. And this is because the innervation on the upper part of the face for those facial muscles comes from both the right and the left side. So if you can see the colors here, so this branch right here is a combination of right and left innervation. So I use this kind of black bar here to show if this is where our lesion is, they're still going to have function of the opposite side, the forehead, but they will not be able to smile. Okay, because that orange branch here is going to be completely involved. With a lower motor neuron lesion, which we see down here, they will not be able to close their eyes, they will not be able to wrinkle their forehead, and they will not be able to smile. So it's going to affect everything on that side. I'm more concerned that you understand the general concept, though, that drooping of the corner of the mouth and failure to close the eyes will be a common symptom for Bell's palsy. Treatment for this is going to include facial muscle exercises. You can use electrical stimulation to help with nerve healing. However, it often requires a specific machine in order to apply the stimulus. Moving on to thoracic outlet syndrome, again another peripheral condition. So this is entrapment caused by pressure from structures in the thoracic outlet. It can compress fibers of the brachial plexus. This includes nerves, arteries, and veins. So don't think that it is nerves only. You can think of it as a neurovascular bundle. And again, typically it is our median nerve that is involved. Compression can occur in a variety of locations. It can occur between the scalenes, which is showing here in A. So the scalene musculature can compress that neurovascular bundle. In B here, you can actually have an extra rib. This is referred to as a cervical rib that can compress tissues. You can also have compression between the typical ribs and the clavicle. So we can also get compression around here. And then you can also get compression here, which is noted in C, underneath the pectoralis minor muscle. We're going to talk about metabolic neuropathies. Diabetic neuropathy, this is going to involve the distal extremity, and it is almost always in a symmetrical pattern. And this is described as a stocking or glove pattern because it covers the entire limb. It is not in a specific dermatome. It often occurs with prolonged hyperglycemia of diabetics and results in decreased sensation. Because of that, we're concerned about the feet of diabetics, so they should check their feet at least 1 to 2 times a day. So this means with decreased sensation, they could cut their foot, step on something, and not feel it. It wouldn't be very painful to them, and they wouldn't treat the injury, and it would also not heal very well. In an alcoholic neuropathy, again, we're going to see distal symmetrical involvement. They're unsure of the exact pathology of this. However, it's going to be similar to our diabetic neuropathy. They're going to have impaired sensation, decreased pain, and it will be in a stocking glove pattern. Individuals with chronic renal failure over time will have atrophy and demyelination of their sensory and motor neurons. So again, the lower extremities are more commonly going to be affected than the upper extremities, but it will be that symmetrical stocking glove type pattern. And our last group here for metabolic neuropathy will be anemia. So similarly, there will be a symmetrical sensory loss that will begin in the feet and the lower legs, and these patients may report pain that progresses to paresthesia.